Hello friends, welcome back to my channel Medicine 101. Today we will talk about neonatal jaundice. So it's one of the most important topic regarding the neonatology. Okay. So what do I mean by neonatal jaundice? Definitely, we can say whenever the value for the bilirubin level that will be more than around, if we give bilirubin value more than 4 to 6%, then we can consider this condition what hyperbilirubinemia. So we can consider this thing as the what neonatal jaundice if we get after the birth. Okay. So in these cases, we need to know some basic, points that around 60% of term, neonates and 80% of preterm neonates can develop the jaundice. We can get the jaundice over here. Okay. Now, when you will see this jaundice within the first week of the life. First week of life. Another thing that is the one of the most important cause for readmission in the hospitals. Okay, after the whenever the delivery will be completed within the first week of the fetus, within the neonatal life, we'll see there is a chances for the readmissions for having the neonatal jaundice over here. Okay, and another thing you have to know over here. The most common morbidity we can get over here for developing the neonatal jaundice. Okay. Last week, if we write it over here, for developing the neonatal jaundice. Okay. Now, whenever we will get in these cases, try to understand. Whenever we get the value for the bilirubin value, if we get more than 6 to 4%, if we get more than 4 to 6%, at that time, at that time we can consider this thing is what the jaundice. Now try to understand in these cases we'll get the two types of the thing. We'll get the physiological jaundice, we'll get the pathological jaundice. Under normal circumstances, we can get also the physiological jaundice. Okay, it's the normal thing. Why I'll talk within subsequent minutes. Okay. First we'll talk about, we'll just compare and contrast in between the physiological jaundice and pathological jaundice. How can you differentiate them? Okay, so let's write it over here and compare them. So I'll write it over here, the physiological jaundice and pathological jaundice. So let's write it over here, physiological jaundice, and I'm writing it over here, the pathological jaundice. Pathological jaundice. Okay. Now how can we differentiate them? Now see, the physiological jaundice, symptoms for these things, and the pathological jaundice, for the symptoms for these things, that will appear in the different times. So, and the first things, if we compare the clinical jaundice, or you can say the physiological jaundice over here, clinical jaundice, this don't develop within 24 hours of life. It can develop after 24 hours. So you can say the clinical jaundice, or you can say the icterus. You can say also the icterus, that will develop after 24 hours. But in terms of the pathological jaundice, it will appear, try to understand, it appears. So you can write it over here, within 24 hours of life. Okay. Now try to understand from here. Now the second thing, what do we know? What are the main causes we will get over here? Okay. In these cases, we will get always, for the development of always, we will get over here the unconjugated bilirubin. We will get unconjugated bilirubin over here, and this will be responsible for causing what? Okay, the physiological jaundice. But in case of, if we say in terms of the Pathological jaundice, here we can get the conjugated bilirubin, it may be increased, or we can get the unconjugated bilirubin. Okay, we can get the conjugated bilirubin or we can get the unconjugated bilirubin. So whenever it will be more, try to understand, definitely we will get the high colored urine over here. Okay, and we will get also changes within the what? Fecal matter, clay, like. Now the third thing we have to write it over here in this way that, see, in these cases, palm and sole, this will be not yellow, it will be negative over here. But in these cases, palm and sole may be yellow. There is chances for having the yellow color within the palm and sole. The most important one in these cases we will get in the physiological jaundice that cannot be seen beyond, for example, the 2 weeks. But in these cases we will get the pathological jaundice can be seen after beyond the 3 weeks also. So let's write it over here. So the physiological jaundice or the clinical jaundice, we can write it over here. Can't be seen beyond 2 weeks. But in these cases we can see the jaundice beyond 3 weeks. You can see the pathological jaundice. Now I'll talk about why we'll see the development of the why do we'll see in terms of the physiological jaundice. Why can you see the development of the physiological jaundice in the neonates? Okay, so let's write it over here. Why we'll see the physiological jaundice. So what do you know? Normally whenever we are getting the neonates, definitely within the neonates, try to understand within the neonates the normal value for what hemoglobin, that will be much more than the adult. So here we will get the hemoglobin value in the neonates that may be around from 60 to 20. So whenever the more amount of the hemoglobin we are getting over here, so there is a chances for the more breakdown of the hemoglobin. So whenever there will be more breakdown of the hemoglobin, so definitely there is a more chances for producing the more amount of the bilirubin. So whenever the more amount of the bilirubin is producing over here, definitely we will get the more chances for developing the neonatal jaundice. This is the one reason. Another reason is over here, we will get the lifespans of the RBC in terms of the neonates, that will be less than the adult. So in case of, try to understand, in case of the neonates, we will get the lifespans for the RBC that will be around 90 days. So if you write it over here, the lifespan of RBC will get around 90 days. So whenever the lifespan of the RBC is less, definitely the RBC that will get breakdown very soon. So whenever RBC that will get breakdown very soon, they will produce more amount of the bilirubin. So more amount of the bilirubin will be produced over here. So there is a chances for developing the physiological jaundice over here. Now another thing over here I have to know, in the neonates we will get the ineffective erythropoiesis. Ineffective erythropoiesis, that means the erythropoiesis process that will be not seen properly. So in this case, another reasons for it we can write that ineffective erythropoiesis. Another thing, try to understand, what do we know, that the conjugations of the bilirubin that is done by what on top of the enzyme, So let's write it over here, then I think it will be more easier. So the enzyme UDP glucuronil transferase. So UDP glucuronil transferase within the neonates is not mature. So we will get the immature UDP glucuronil transferase. So in these cases, whenever we will get this the immature, so it will be not able to convert the unconjugated bilirubin to conjugated bilirubin. As a result, we can see there is a chances for developing the jaundice. The third thing I have to do over here, okay, we will write ineffective carrier mediated for the uptake of the liver. Let's explain this one. In these cases, we will see the ineffective, there will be not proper uptaking. There will not proper uptaking of the what this conjugated bilirubins within the liver properly. So as a result, we will see in these cases the development of the what will get the development of the physiological jaundice. Let me repeat once again. If we get what do you know normally within the neonate the hemoglobin level that is much. So whenever the hemoglobin is more, there is a more chances for the breakdown of the RBC. So whenever the whenever we get more breakdowns of the RBC, there will be more productions of the bilirubin. So one reason for developing the jaundice. The second thing is over here, the life expectancy for the RBC within the newborn is less than the adults. We will get around 90 days. So there is the more chances for the RBC to get breakdown very soon over here. So we'll get more amount of the bilirubin. And third thing, we'll get the ineffective erythropoiesis over here. And the fourth one, in this case, we'll get the UDP glucuronide transferase. UDP glucuronide transferase enzyme, that is immature. So whenever it will be immature, definitely the conjugated bilirubin that will be not. Definitely will get the unconjugated bilirubin that will be much more over here. Okay. So because this enzyme is not working, so definitely the unconjugated bilirubin that will be not converted into conjugated bilirubin. So definitely will get over here. Okay. Now we'll talk about the different another things over here. That's the breast feeding jaundice and breast milk jaundice. So it's one of the most important topic being write it over here, because these things that confuse the students, that what do you mean by breast feeding jaundice and what do you mean by breast milk jaundice. So let's write it over here. If I write that breast feeding jaundice, and if you write it over here that milk, okay, breast milk jaundice, we'll compare and contrast in between them. Okay. See, if we see in terms of the try to understand, if we see in terms of the breastfeeding jaundice, if we see the the mothers, if we see the mothers, not the individuals or the neonates is not having the the good enough breastfeeding. Whenever the individuals or you can say the neonate is not having the good enough what breastfeeding. So if you see the lack of breastfeeding over here, at that time there will be deficiency of the fluid, or you can say within the neonates, or whenever there is deficiency of the fluid, definitely we can see the process of the polycythemia, because the more amount of the there will be more amount of the erythropoiesis. As a result, we will get over here the polycythemia. We get the polycythemia. Whenever we get the polycythemia, the RBC mass, the number of the RBC, that will be much more. So with the more amount of the RBC, definitely there will be more chances for the more getting the chances for getting more amount of the bilirubin. So whenever we get the more amount of the bilirubin, that will develop the jaundice. So in these cases we can get. Now what will be the treatment for these things? We are supposed to advise the mother that the mother should do the frequent breastfeeding. In these cases we can say the frequent breastfeeding. Okay. Now what about the breast milk jaundice? Breast milk jaundice, that means there should be some substances that is present where milk, that is what? That is inhibiting within the transformations of the unconjugated bilirubin into conjugated bilirubin. So for example, if you write it over here, in terms of the breast milk jaundice, okay, the substance present within milk. For example, if we write it over here, pregnanidiol, or you can, if you get the free fatty acid. Now these two things, for example, the pregnanidiol and the free fatty acids, they can inhibit the enzymes. They can inhibit the enzymes that will convert the unconjugated bilirubin into conjugated bilirubin. So inhibition in what? Conversion. In conversion of unconjugated bilirubin to conjugated bilirubin, this process will be inhibited. As a result, we can see there will be also development of the jaundice over here, and this type of the jaundice is breast milk jaundice. Now, if we see, yet we were supposed to, we were supposed to say the mother that she should continue the breastfeeding. So in these cases, supposed to say that breastfeeding that should be continued. The breastfeeding that should be held if we see the bilirubin level. If you see the bilirubin level that is going beyond 20, if you get beyond 20, then at the time we can say that breastfeeding that should be held for a while. After that again the breastfeeding that should be held, because we don't have any kind of the medications. The only food, the fluid, whatever you can say, that is the breastfeed for the neonates at that time. So these things will get in terms of the milk, breast milk. This thing is the word breastfeeding jaundice over here. Okay. Now we'll talk about pathological jaundice. What are the causes for the causing the pathological jaundice or etiologies? So let's talk about them. So let's write it over here. The pathological jaundice. If we write in terms of the pathological jaundice, what type of thing we'll get over here? Pathological jaundice. Now see, the pathological jaundice that can be developed for the unconjugated bilirubin, that can be also developed for the. At first we'll talk about that the pathological jaundice for the unconjugated bilirubin. Now if you see the unconjugated bilirubin, that is getting increased over here, and that is causing the jaundice over here. What type of the regions we can get over here? Now unconjugated bilirubin that can be increased for the two regions. One we can say over here, the productions of more bilirubin. The productions of more bilirubin. Another thing we can say over here, less conversion of unconjugated bilirubin into conjugated bilirubin. What are the regions? If we just talk in terms of the pathological jaundice, for what we are getting the more amount of the unconjugated bilirubin. Unconjugated bilirubin that can be increased for the two regions. One, if we get the productions of the bilirubin that is greater, that is what? That is much more. And if we get the less conversions of the unconjugated bilirubin to conjugated bilirubin. Now we'll talk about first the why we'll see the productions of the more amount of the bilirubin. The first thing, of the first region we can say over here, if we get the hemolytic anemia. So whenever we get the hemolytic anemia, there will be more breakdown of the what? RBC. So more chances for the producing of what? More amount of the bilirubin. The second region, that's the most important one. Let's show the different color. Erythroblastosis fetalis. Now the other regions will get over here. The hereditary dysperosis. You can write it over here. Hereditary dysperosis. We can get also the G6DP deficiency, glucose 6 phosphate deficiency. You can get it over here. We can get also the polycythemia. Okay, so these will be the regions. Okay, there are much more regions, and I have just said the important one. But the most common cause for the productions of the more amount of the bilirubin in terms of the unconjugated bilirubin over here, the most common cause that will be the erythroblastosis fetalis. So it will be the most common cause that is responsible for increasing the value for unconjugated bilirubin, and that will lead to the pathological jaundice over here. Okay. Now we'll talk about the less conversions of the unconjugated bilirubin to conjugated bilirubin. That means we know that I have already said you that UDP, glucuronide transferase, that is responsible for the conversion of what? Unconjugated bilirubin to conjugated bilirubin. And if you see the enzyme is not functional, if you see the dysfunction within the enzymes, that these conversions will be not done properly. So whatever the disease will get, certain types of the disease for these things, let's write it over here. Okay, so let's use this one. So first thing we'll get over here, Crigler-Najjar syndrome. So Crigler-Najjar syndrome, whatever the thing we'll get over here, in terms of the Crigler-Najjar syndrome, we'll get the two types. We'll get type 1 and type 2. If we get type 1 and type 2, Okay, let's use the different color for it, guys. See, in type 1, whatever the problem we'll see, the enzyme UDP I have already said, glucuronide transferase. In type 1, Crickland-Najjar syndrome, we will get in type 1 Crickland-Najjar syndrome, will, in these cases, there will be complete loss, the complete dysfunctions of the UDP, that means what? UDP glucuronide transferase. In these cases, we will get the completely, it will be the functionless. In type 2, we will get what? In terms of the type 2, if we say, in type 2, we will get the partial loss of functions for the UDP GT, that means UDP glucuronide transferase. So this is the one regions. And the regions we can get also over here. Okay, let's show over here in these places. Other regions, pathological regions, we can get it over here. There is the Gilbert Syndrome. You can get the Gilbert Syndrome. Along with the Gilbert Syndrome, we can also see in terms of the Down Syndrome. Okay, and also you can see congenital hypothyroidism. So see, these are the regions for which you can see, and the regions that will that is having the effect within the enzymes. So you can see in terms of the Gilbert syndrome, Down syndrome, and congenital hypothyroidism over here. So these will be the regions as far as the less production, so you can say the less conversions of what? The UCB, that means unconjugated bilirubin to the conjugated bilirubin. So this will be the normal regions. The next part of the videos we will talk about how can we manage these situations. Okay, so we'll talk about the management in the next part of the videos. This is all about the first part, neonatal jaundice part 1. You can see over here what are the regions, what is the physiological jaundice, what is the most important, the breastfeeding jaundice, what is the breast milk jaundice, okay, and what is the pathological jaundice. In pathological jaundice, I have just explained only for the pathological jaundice if it develops for the increased value for the unconjugated bilirubin. And in the next part of the video, at first I will talk about if we get the more amount of the conjugated bilirubin over here. Okay, if we get the value for the conjugated bilirubin that is much more, at that time what are the causes for these things and what type of the treatment you can get for these things. We'll talk about all these things in the subsequent videos. Okay, so thanks for watching. If you don't get any point related to this, please let me know in the comment section.